Dharmadhikhari from Harvard CFAR, and he's going to talk to us about inhaled antimicrobials, a novel approach to reducing MDR-TB transmission in congregate settings with HIV.
Okay, well, I'd like to thank the meeting organizers for this opportunity to present this work today. So, the transmission of tuberculosis remains an important threat to the control and management of both tuberculosis and HIV. In high-burden settings, such transmission is responsible for over half of new cases of drug-resistant tuberculosis, especially in the setting of reinfection. And in hospitals and other congregate settings, transmission like this puts other occupants, including patients with other illnesses or healthcare workers, at risk for TB infection. You know, it's clear that there are new approaches urgently needed to reduce the spread of TB, but there's been no fundamentally new developments in transmission control in over half a century. In these same high-burden settings, traditional approaches to reducing the spread of TB, like airborne isolation, is just of limited efficacy because of, one, limited resources, limited space, and an overwhelming burden. And while it's recognized that effective treatment renders TB patients non-infectious fairly rapidly after the initiation of treatment, especially for drugs susceptible to tuberculosis, and with evidence emerging that the same is true for drug-resistant MDR-TB, there are two important caveats to sort of the widespread truth behind this phenomenon. One is that it really requires that patients be diagnosed with drug resistance rapidly and be put on a regimen to which their infecting strain is susceptible in a timely manner. And secondly, we recognize that regimens for XDR tuberculosis are of significantly lower efficacy than those for drug-susceptible or MDR-TB. And so patients with XDR may remain infectious for longer periods of time. So in that regard, we're seeking to evaluate a new approach to interrupting TB transmission, recognizing that the TB bacilli that will be transmitted are most likely, almost exclusively going to originate in aerosols formed from the main airways, or trachea, for example, of patients with tuberculosis. This approach seeks to deliver inhaled antibiotics through patient self-administration, for example, to those central airways, and to achieve concentrations of those antibiotics that are significantly above the inhibitory concentration of those bacilli that are viable and that are most likely to be transmitted. So we are pursuing an evaluation of inhaled dry powder colistin, also known as polymyxin E, for this purpose of transmission control. Colistin has traditionally been used for the treatment of gram-negative bacterial infections. And unlike drugs used for tuberculosis to date, colistin may be particularly attractive because it actually doesn't depend on inhibiting pathways involved in TB replication for its efficacy. It works primarily by actually poking holes in the cell membrane. And prior in vitro work has shown that the MIC and MBC for colistin, of colistin for M. tuberculosis, are 5 and 50 micrograms per ml respectively. You know, unfortunately, in order to get these sorts of drug levels in the lungs of patients with tuberculosis requires doses that are so high that they often result in systemic toxicity to those individuals, in particular kidney injury is sort of the most dreaded toxicity. So in contrast, using direct delivery of the drug to the airways could achieve two potential purposes or endpoints. One is it would target high doses to the sites from which TB bacilli are going to be transmitted. And secondly, with a well-engineered drug of appropriate particle size characteristics, you might actually avoid the spikes in the high doses and levels that are seen that result in systemic toxicity. So our hypothesis of this study of inhaled colistin is as follows: that M and XDR tuberculosis patients receiving systemic treatment for their pulmonary TB plus inhaled dry powder colistin will be rendered 75% less infectious compared to those same patients during periods when they are receiving or on systemic treatment alone. So we're conducting this research at the Airborne Infections Research Facility in South Africa. This is a facility that was developed and which we've used specifically to test infection control interventions against tuberculosis. It consists of a 6-bed inpatient TB ward and 2 animal exposure chambers that house 90 guinea pigs each. And the only connection between the guinea pig exposure chambers and the patient ward is a unidirectional ventilation system that exhausts all of the air from the patient ward and sends it to one or the other guinea pig colony on an alternating basis, thereby essentially taking the aerosols produced by the TB patients during their occupancy of the ward and sending it over to the guinea pigs for the purposes of exposing and infecting them with tuberculosis. So in this study design, one group of guinea pigs receives air when the patients are receiving inhaled colistin, and that's called the intervention group. And the other group of guinea pigs receives air from the ward when the patients are not on the intervention of interest, and it's called the control group. So the patients in these studies, they're there to take inhaled colistin, but they're also primarily there to serve as sources of aerosol to expose and infect the guinea pigs. In our study, they consist of adult male and female patients with smear and culture-proven M or XDR tuberculosis. And we don't cohort these together, so our cohorts are either or. And they consist of a mix of HIV-infected and uninfected patients, really reflecting the demographics of the patient population from which we enroll that are in the satellite hospital there. And I'll just say, as a side note, that in our studies to date, about 60 to 70% of our patients have been HIV-infected. And this inset just shows the extent of the radiographic progression of disease of these individuals at the time that they're coming into our study. So they've got a very advanced pulmonary lung disease. So these patients are also entering our ward just as they're initiating systemic treatment for their form of M or XDR tuberculosis according to South African guidelines. So we're really capturing them at the time when they're most likely to be infectious, before systemic treatment has had a chance to take effect. They also receive HIV treatment according to South African guidelines. And we have a couple of other inclusion and exclusion criteria mainly aimed at avoiding the enrollment of patients with asthma or other obstructive lung diseases that might be aggravated by this inhalation, and avoiding the enrollment of patients with existing kidney injury. So these patients self-administer the dry powder colistin using a pretty easy-to-use handheld device called the Twincer, developed by our colleagues at the University of Groningen in the Netherlands. And here's just an inset showing a picture of the Twincer and how a patient would actually self-administer the drug. They take 25 milligrams every 8 hours for 7 days straight, and they alternate that with a 7-day period during which they don't receive inhaled colistin but continue on their systemic treatment for M or XDR-TB. And the particle size of the drug that we're using has a range of 1 to 5 micrometer diameter. So each patient spends 1 month in our research ward. And so what that translates into is 2 weeks taking inhaled colistin with systemic treatment and 2 weeks off of colistin in that alternating basis I described, with air going to one guinea pig cohort or the other. We plan a 4-month duration of the study, so 4 cohorts of patients will pass through the ward during the study. And in terms of looking for guinea pig infections, we do that by doing a tuberculin skin test on the guinea pigs to look for incident infections. And here's just a diagram showing how we carry that out and how we measure the tuberculin skin test reaction. So this study is about halfway complete. So here are some interim results of this work in progress. So as you can see, at baseline, these guinea pigs, the 90 in each group, were free of TB infection with no reactions to tuberculin skin test. At the end of 1 month of study, which really meant 2 weeks on colistin and 2 weeks not on colistin among the patients, there were 8 out of 90 guinea pig infections in the intervention group and 18 out of 90 guinea pig infections in the control group, giving us, at that point at least, about a slightly more than 50% reduction in transmission with the use of inhaled colistin. And then at the end of the 2nd month of study, as you can see here with TST2, we actually had no new guinea pig infections in either group of guinea pigs. And so presumably what this means is that despite our best efforts to try to enroll and recruit patients that would be presumably infectious, they actually were not sufficiently infectious to generate any infections even under controlled conditions. And we have additional anticipated results based on additional months of study. And at the end, what we really hope to have is a comparison of the numbers of guinea pigs infected under each of these 2 conditions. So I will also note that these inhalations of colistin have been very well tolerated by the patients. with no increases in cough or wheezing, which might be a side effect of this inhaled therapy, and there's been no other adverse events to date either. So as I mentioned, we'll have the additional data forthcoming in the next couple of months to give us really our measure of the primary efficacy endpoint, which is reducing transmission to the guinea pig as a surrogate host. But in addition to that, we're also going to be exploring a secondary endpoint, which is what, if any, effect of inhaled colistin might there be on the patient's disease burden. And we're going to do that by looking at time to sputum culture conversion among the sputum samples collected while on colistin versus while not on colistin. So with that, I'll thank you for your attention, and just want to acknowledge the both financial and institutional contributions of a variety of organizations, in particular individuals at the CFAR and in South Africa, without whose help along the way in the planning would not have made the study possible or gotten us to where we are today. So thank you.
Questions? Bill?
How do you deliver, how do you aerosolize this colistin?
So we don't aerosolize. The way the Twinster device works is that the patient basically puts their mouth to the inlet, and they take a deep breath in, and that process of actuation allows the dry powder to basically come out of the Twinster and go into their main airways and lungs.